Welcome to the Dr. Izzy's Medical Podcast channel.
Pituitary adenomas are tumors that occur in the pituitary gland. Pituitary adenomas are generally divided into three categories dependent upon their biological functioning: benign adenoma, invasive adenoma, and carcinomas. Most adenomas are benign, approximately 35% are invasive, and just 0.1% to 0.2% are carcinomas. Pituitary adenomas represent from 10% to 25% of all intracranial neoplasms, and the estimated prevalence rate in the general population is approximately 17%. Non-invasive and non-secreting pituitary adenomas are considered to be benign in the literal as well as the clinical sense. However, a recent meta-analysis of available research has shown there are to date scant studies, of poor quality, to either support or refute this assumption. Pituitary macroadenomas are the most common cause of hypopituitarism. Signs and symptoms. Hormone-secreting pituitary adenomas cause one of several forms of hyperpituitarism. The specifics depend on the type of hormone. Some tumors secrete more than one hormone, the most common combination being growth hormone and prolactin, which present as unexpected bone growth and unexpected lactation, in both men and women. A patient with pituitary adenoma may present with visual field defects, classically bitemporal hemianopsia. It arises from the compression of the optic nerve by the tumor. The specific area of the visual pathway at which compression by these tumors occurs is at the optic chiasma. The anatomy of this structure causes pressure on it to produce a defect in the temporal visual field on both sides, a condition called bitemporal hemianopsia. If originating superior to the optic chiasm, more commonly in a craniopharyngioma of the pituitary stalk, the visual field defect will first appear as bitemporal inferior quadrant enopia. If originating inferior to the optic chiasm, the visual field defect will first appear as bitemporal superior quadrant enopia. Lateral expansion of a pituitary adenoma can also compress the abducens nerve, causing a lateral rectus palsy. Also, a pituitary adenoma can cause symptoms of increased intracranial pressure. Prolactinomas often start to give symptoms, especially during pregnancy, when the hormone progesterone increases the tumor's growth rate. Various types of headaches are common in patients with pituitary adenomas. The adenoma may be the prime causative factor behind the headache or may serve to exacerbate a headache caused by other factors. Amongst the types of headaches experienced are both chronic and episodic migraine, and more uncommonly various unilateral headaches, primary stabbing headache, short-lasting unilateral neuralgiform headache, attacks with conjunctival injection and tearing, another type of stabbing headache characterized by short stabs of pain, cluster headache, and hemicrania continua. Compressive symptoms of pituitary adenomas, visual field deficits, decreased visual acuity, headaches, are more commonly seen with macroadenomas, which are greater than 10 mm in diameter, than with microadenomas, which are less than 10 mm in diameter. Non-secreting adenomas can go undetected for an extended time because no obvious abnormalities are seen. The gradual reduction in normal activities due to decreased production of hormones is rather less evident. For example, insufficient adrenocorticotropic hormone means that the adrenal glands will not produce sufficient cortisol, resulting in slow recovery from illness, inflammation, and chronic fatigue. Insufficient growth hormone in children and adolescents leads to diminished stature, but which can have many other explanations. Psychiatrical signs. Various psychiatric manifestations have been associated with pituitary disorders, including pituitary adenomas. Psychiatric symptoms such as depression, anxiety, apathy, emotional instability, easy irritability, and hostility have been noted. Complications. Acromegaly is a syndrome that results when the anterior pituitary gland produces excess growth hormone. Approximately 90 to 95% of acromegaly cases are caused by a pituitary adenoma, and it most commonly affects middle-aged adults. Acromegaly can result in severe disfigurement, serious complicating conditions, and premature death if unchecked. The disease, which is often also associated with gigantism, is difficult to diagnose in the early stages and is frequently missed for many years, until changes in external features, especially of the face, become noticeable, with the median time from the development of initial symptoms to diagnosis being 12 years. Cushing's syndrome is a hormonal disorder that causes hypercortisolism, which is elevated levels of cortisol in the blood. Cushing's disease is the most frequent cause of Cushing's syndrome, responsible for approximately 70% of cases. Cushing's disease results when a pituitary adenoma causes excessive secretion of adrenocorticotropic hormone that stimulates the adrenal glands to produce excessive amounts of cortisol. Cushing's disease may cause fatigue, weight gain, fatty deposits around the abdomen and lower back, truncal obesity, and face, moon face, stretch marks on the skin of the abdomen, thighs, breasts, and arms, hypertension, glucose intolerance, and various infections. In women, it may cause excessive growth of facial hair, hirsutism, and in men erectile dysfunction. Psychiatric manifestations may include depression, anxiety, easy irritability, and emotional instability. It may also result in various cognitive difficulties. Hyperpituitarism is a disease of the anterior lobe of the pituitary gland which is usually caused by a functional pituitary adenoma and results in hypersecretion of adenohypophyseal hormones such as growth hormone, prolactin, thyrotropin, luteinizing hormone, follicle-stimulating hormone, and adrenocorticotropic hormone. Pituitary apoplexy is a condition that occurs when pituitary adenomas suddenly hemorrhage internally, causing a rapid increase in size, or when the tumor outgrows its blood supply, which causes tissue necrosis and subsequent swelling of the dead tissue. Pituitary apoplexy often presents with visual loss and sudden onset headache and requires timely treatment, often with corticosteroids and if necessary surgical intervention. Central diabetes insipidus is caused by diminished production of the antidiuretic hormone vasopressin that causes severe thirst and excessive production of very dilute urine, which can lead to dehydration. Vasopressin is produced in the hypothalamus and is then transported down the pituitary stalk and stored in the posterior lobe of the pituitary gland, which then secretes it into the bloodstream. As the pituitary gland is in close proximity to the brain, invasive adenomas may invade the dura mater, cranial bone, or sphenoid bone. Mechanism. The pituitary gland or hypophysis is often referred to as the master gland of the human body. Part of the hypothalamic pituitary axis, it controls most of the body's endocrine functions via the secretion of various hormones into the circulatory system. The pituitary gland is located below the brain in a depression, fossa, of the sphenoid bone known as the sella turcica. Although anatomically and functionally connected to the brain, the pituitary gland sits outside the blood-brain barrier. It is separated from the subarachnoid space by the diaphragma sella, therefore the arachnoid mater and thus cerebral spinal fluid cannot enter the sella turcica. The pituitary gland is divided into two lobes, the anterior lobe, and the posterior lobe, separated by the pars intermedia. The pituitary gland's anterior lobe, adenohypophysis, is a true gland which produces and secretes 6 different hormones: thyroid-stimulating hormone, adrenocorticotropic hormone, follicle-stimulating hormone, luteinizing hormone, growth hormone, and prolactin. Diagnosis. Diagnosis of pituitary adenoma can be made, or at least suspected, by a constellation of related symptoms presented above. The differential diagnosis includes pituitary tuberculoma, especially in developing countries and in immunocompromised patients. The diagnosis is confirmed by testing hormone levels, and by radiographic imaging of the pituitary, for example, by CT scan or MRI. Classification. Unlike tumors of the posterior pituitary, pituitary adenomas are classified as endocrine tumors, not brain tumors. Pituitary adenomas are classified based upon anatomical, histological, and functional criteria. Anatomically, pituitary tumors are classified by their size based on radiological findings, either microadenomas, less than 10 mm, or macroadenomas greater than or equal to 10 mm. Classification based on radioanatomical findings places adenomas into one of 4 grades. Stage 1, microadenomas, less than 1 cm, without cella expansion. Stage 2, macroadenomas, greater than or equal to 1 cm and may extend above the cella. Stage 3, macroadenomas with enlargement and invasion of the floor or supracellular extension. Stage 4 is destruction of the cella. Treatment. Treatment options depend on the type of tumor and on its size. Prolactinomas are most often treated with cabergoline or quinagalide, both dopamine agonists, which decrease tumor size as well as alleviate symptoms, followed by serial imaging to detect any increase in size. Treatment, where the tumor is large, can be with radiation therapy, proton therapy, or surgery, and patients generally respond well. Unlike prolactinomas, thyrotrophic adenomas characteristically respond poorly to dopamine agonist treatment. Somatotrophic adenomas respond to octreotide or lenreotide, which are long-acting somatostatin analogs. These somatostatin receptor analogs inhibit secretion of growth hormone. They were found to be about 50 to 55% effective in reducing tumor mass and reducing growth hormone and insulin-like growth factor 1 levels in studies. The growth hormone receptor antagonist pegvisomant is also used in the treatment of somatotrophic adenomas. Pegvisomant blocks the action of growth hormone. It can either be used as monotherapy or combined with a somatostatin analog. Surgery is a common treatment for pituitary tumors. The normal approach is transsphenoidal adenectomy, which usually can remove the tumor without affecting the brain or optic nerves. Radiation is also used to treat pituitary adenomas. Examples include external beam or proton beam radiation therapy or stereotactic radiosurgery. External radiation of pituitary adenomas can arrest tumor growth for several years, but pituitary failure develops within 10 years in most patients, necessitating lifelong hormone replacement. Radiation therapy for pituitary adenomas is associated with a 4-fold increase in mortality due to cerebrovascular disease.
Thank you for listening Dr. Izzy's medical podcast series. If you want to support this project, please subscribe the channel and like this video. Thank you.